To set the context for our project, I'll start by briefly discussing triple-negative breast cancer, its clinical characteristics, and why there is a strong need for improved prognostic and predictive biomarkers. Breast cancer is a heterogeneous disease, and triple-negative breast cancer is one of its most aggressive subtypes. It is defined by the absence of estrogen receptors, progesterone receptors, and HER2 expression. Because of this, common targeted therapies such as hormonal or HER2-targeted treatments are not effective. Triple-negative breast cancer accounts for about 10 to 20% of all breast cancer cases. Triple-negative breast cancer is associated with aggressive tumor biology. Patients often experience earlier recurrence, higher metastatic rate, and poorer overall survival. It is also highly heterogeneous at the molecular level, meaning tumors can behave very differently, which makes outcomes harder to predict. From a clinical perspective, triple-negative breast cancer presents several major challenges. First, patients generally have poorer prognosis compared to hormone-positive or HER2-positive breast cancers. Second, due to the lack of receptors that can be targeted, chemotherapy remains the main treatment options for many patients. While immunotherapy has shown promise, particularly with immune checkpoint inhibitors, only a subtype of triple-negative breast cancer patients benefit from these approaches. This variability highlights the need for better tools to predict outcomes and treatment responses. Currently, chemotherapy remains the backbone of triple-negative breast cancer treatment, but responses are inconsistent and often associated with significant toxicity. Although immune checkpoint inhibitors have improved outcomes in some patients, there is still no reliable way to identify which patients will benefit the most. This reinforces the importance of identifying biomarkers that can guide therapeutic decision-making. This table summarizes key clinical trials on immunotherapy in triple-negative breast cancer. Overall, treatments such as pembrolizumab show benefit, especially when combined with chemotherapy. However, responses vary significantly, and benefits are often limited to specific subgroups. This highlights the lack of reliable predictive biomarkers. Biomarkers play a critical role in modern oncology. Prognostic biomarkers help predict disease outcomes, while predictive biomarkers help identify patients who are most likely to respond to specific therapies. Given the biological heterogeneity of triple-negative breast cancer, reliable biomarkers could significantly improve patient stratification, reduce overtreatment, and support more personalized therapeutic approaches. Despite extensive research, there is currently no universally accepted prognostic or predictive biomarker routinely used in triple-negative breast cancer clinical practice. As a result, treatment decisions are often empirical rather than biomarker-driven, which limits precision medicine approaches in this aggressive subtypes. So, in summary, triple-negative breast cancer is an aggressive and heterogeneous disease with limited targeted treatment options, and there is no clear unmet need for biomarkers. This clinical gap provides the need for exploring novel molecular and immunological markers such as cancer-testis antigens, leading to the next section on NY-ESO-1.
Cancer-testis antigens are a type of tumor-associated antigens that are normally expressed in male germ cells and in very low amount in the placenta during embryogenesis. These antigens are absent in somatic tissues, however, they are aberrantly activated and expressed in malignant cells. What makes CTAs attractive for cancer research are four reasons. Their tumor-specific expression, which minimizes off-target effects, their absence from normal tissues, which makes them highly immunogenic. They are suited for vaccines, T-cell therapies, and antibody-based approaches, and they serve as both diagnostic and predictive biomarker. So now we come to our candidates, NY-ESO-1, which is one of the most well-characterized cancer-testis antigens. NY-ESO-1 stands for New York esophageal squamous cell carcinoma 1. It is encoded by the CTA-G1B gene, and it's virtually absent in normal tissues, but aberrantly expressed in several cancers. And what makes it stand out is its strong immunogenicity. Because it is restricted to immune-privileged tissues, the immune system is not tolerized to it. So when tumors express it, especially the NY-ESO-1, triggers both T cells and antibody responses, activating the full immune arsenal against the tumor. So its expression varies across breast cancer subtypes, with the highest rates in triple-negative breast cancer, around 9 to 18%, compared to just 0 to 5% in HER2 positive and under 4% in luminal subtypes. This professional expression in TNBC highlights NY-ESO-1 as a subtype enriched biomarker, particularly relevant for aggressive breast cancer where targeted treatment options are limited. So, as we can see here in these charts, TNBC in patients with NY-ESO-1 expressing tumors demonstrate significantly improved disease-free survival and overall survival compared to those without NY-ESO-1 expression. And this finding is interesting because TNBC is generally considered an aggressive subtype with poor prognosis.
Clinically, NY-ESO-1 is important in triple-negative breast cancer because it helps address two key questions: which tumors show more aggressive biological behavior and which are more likely to respond to immunotherapy. TNBC is highly heterogeneous, meaning patients with the same diagnosis can have very different outcomes. Biomarkers like NY-ESO-1 help distinguish these differences. Its clinical relevance can be understood in two areas: prognosis and prediction. From a prognostic perspective, NY-ESO-1 is expressed in approximately 10% of TNBC tumors. These tumors tend to show higher levels of tumor-infiltrating lymphocytes, indicating an active immune environment. When NY-ESO-1 is present, especially alongside high TILs, patients tend to have better outcomes, while absence of both is associated with shorter disease-free survival. Survival data supports this pattern, showing that both NY-ESO-1 negativity and low TIL density are linked to poorer outcomes. This suggests that NY-ESO-1 defines an immune-active TNBC subset with a more favorable prognosis. Beyond prognosis, NY-ESO-1 also has predictive value for immunotherapy. As a highly immunogenic antigen, it is associated with strong immune activity, including antigen-specific T cell responses. NY-ESO-1 positive tumors often show dense TIL infiltration, which is linked to better responses to checkpoint inhibitors. Clinically, this supports using NY-ESO-1 immunohistochemistry to identify patients who may benefit from targeted therapies such as TCR T cell treatments. This is supported by quantitative data showing that approximately 16% of TNBC tumors express NY-ESO-1, nearly 8 times higher than in hormone receptive positive cancers. These tumors also show higher CD8 positive T cell infiltration, indicating an active cytotoxic immune response. Together, this supports NY-ESO-1 as a practical screening biomarker to identify patients most likely to benefit from immunotherapy. Based on this, our study aims to evaluate NY-ESO-1 expression in TNBC to support personalized therapy and generate locally relevant data. To achieve this, we will assess NY-ESO-1 expression across cell lines, tissue samples, and patient cohorts, and correlate these findings with clinical features and immune responses. This will help clarify its prognostic and predictive value in TNBC. Together, this provides a foundation for translating NY-ESO-1 into clinical practice, which will be discussed in the next section.
The study design is a prospective pre-post study conducted over 2 years, focusing on one group of TNBC patients in Burjeel Medical City, Abu Dhabi. The samples include peripheral blood and formalin-fixed paraffin-embedded tumor tissue. The inclusion criteria include patients newly diagnosed with TNBC and starting treatment, while the exclusion criteria is patients who have other cancer types or those who decline to participate. The samples are taken at two key time points: before treatment for the baseline and after treatment within 3 to 6 months. For the detection strategy, NY-ESO-1 expression is measured using qPCR and then validated using tissue microarray analysis. In addition, immune profiling is performed using flow cytometry to assess key immune cells such as CD4 and CD8 T cells, as well as checkpoint markers like PD-1 and PDL-1. For data analysis, correlation and regression are used to assess whether NY-ESO-1 expression is linked to clinical factors like tumor stage, severity, and treatment outcomes. Kaplan-Meier analysis evaluates patient survival based on NY-ESO-1 levels, helping to determine its prognostic value. And statistical tests, including paired t-tests and Wilcoxon tests, compare changes before and after the treatment while using a p-value of less than 0.05 to indicate significance. NY-ESO shows great promise as both a prognostic biomarker and an indicator of immune response. Because it can be detected through blood samples, it also supports minimally invasive monitoring, and it enables patient stratification by identifying which patients are more likely to benefit from immunotherapy as well as not, and supports more personalized treatment decisions, contributing to precision oncology in the UAE healthcare system. For the limitations of the study, it is conducted at a single center, which may limit how widely the findings can be applied. Additionally, the moderate sample size may reduce statistical power, and tumor heterogeneity can also affect the consistency of results. Future research focuses on larger multi-center studies to improve reliability. There's also potential to develop regional databases of NY-ESO-1 expression, particularly within the United Arab Emirates, and to explore targeted therapies such as NY-ESO-1 based vaccines and immunotherapies. These advancements further support personalized treatment strategies. In conclusion, NY-ESO-1 shows strong promise as a tumor-associated immunological biomarker in TNBC, and combined tumor and immune profiling provides deeper insight into disease behavior, and this can address a critical research gap in the UAE when it comes to TNBC biomarker studies. Thank you for this opportunity and your attention.